pathogenesis. You guys took it last year, but please focus على antibodies again. So this is TSH receptor antibody. This is stimulus. This antibodies goes to the thyroid glands and asking it to actually release more hormones. So this antibodies resemble the TSH being released by the pituitary, fooling a thyroid disease to release more hormones. Okay. Graves' disease may precipitated by pregnancy, iodine access, viral or bacterial infection, lithium therapy for people with bipolar disease, as well as glucocorticoid withdrawal. Okay. Notice that the ophthalmopathy, again, it's very heavily associated with grave disease. It has a very unique, actually, pathogenesis, and this is why we always are very careful treating people with Graves' disease with ophthalmopathy. What are the symptoms? Okay, it's tachycardia, a tremor, shivering, sweating, lid lag in the eye, as well as basically increasing the circulation of catecholamine. Those are the eye feature. You don't need to memorize them by heart, but just understand it's not present or absent. There is actually a kind of classes, features. It can be having no symptoms whatsoever, and they actually can present with optic nerve involvement and sight loss, and everything in between, including just lid retraction, stare, lid lag. It can be actually periorbital edema, redness in the conjunctiva, chemosis. It can be actually proptosis, which is probably the classic symptoms for eye involvements and grave disease. So basically, you are feeling that the eye is bulging out of the eyeball area. They can actually have extraocular muscle movement as well as corneal involvement, because all the eye is bulging out of the head. Okay. Of course, goiter. Sometimes you'll notice some bruit. That's meaning there is just hyper circulation of blood in the thyroid gland. Dermopathy, so you can actually have thickening of the skin, especially around the tibial area. You can actually especially see it when you have high TSH antibodies. Clinical feature you guys know about from the 5th year, so we're not going to spend a lot of time over it. How to make a diagnosis? Again, it's heavily rely on the thyroid hormone results. So we are talking about suppressed TSH, so very low TSH. Sometimes it's actually even undetectable. We have a high free T4 and T3. The eye involvement is really suggestive of grave disease. So the symptoms may say this is hyperthyroidism, but when you see an eye involvement, this is highly suggestive of grave disease in particular. You can actually do a radioiodine uptake scan. You will see a diffuse uptake because all the thyroid glands are actually releasing and manufacturing more thyroid hormones. Okay, and we talked about the TSH antibody stimulus, which have a different name. Sometimes they call it TRAP, sometimes they call it TSH antibody stimulus, which is a very specific for a grave disease, happen up to, I think, 90% of people. Again, so what do you guys see abnormal in this picture? Oxalmophthalmos. Okay, goiter. Okay, I agree with goiter. Be more specific with oxophthalmos. Like, what do you see in the oxophthalmos? Bulging. You feel it's bulging, yeah? That's all very, very valid point. Protruded eye, good. How did you know the eyes are protruded? That's my question. Okay, you guys, we don't know there is actually loss of ocular muscle. Okay, okay, lid retraction, good, good. So you guys focus, you see this white part of the eye in the lower end here? You guys all see it, صح? Clearly. So that is normal. But what's abnormal that you see actually the whiteness above over here, okay? So when you actually focus in someone else's eyes, you wouldn't see the whole eyes. You're only gonna see the white in the lower end, but not in the upper end. Is this clear, guys? Okay, good. But I agree, the first impression is, oh, the eyes is bulging out. There is oxophthalmos. But sometimes we'll have to find very specific subtle finding. And this, we shouldn't see the whitish material here above the eye. It's actually abnormal to see them. Okay, here is more clearly. What else we see here? Again, we see the white above. What else? Sweating, good. And we see this congestion, this redness, this chemosis in the eyes, okay? And here it's bulging. So whenever you are actually like to confirm the bulging, you see it from the side better than from the front. Oh boy. Okay. So how do we treat Graves' disease? In general, we have three options: medical, surgical, radioactive iodine therapy. When it comes to the medical, we are talking about anti-thyroid drug therapy, okay? And this is helpful for small gland or mild disease. And usually we give it for a year, 2 years, and then we can stop it and see whether the disease is relapsing or not. There is a high chance of relapse with Graves' disease, up to 50%. 50% relapse is actually very high. We have two types of drug. We have the methimazole, carbamazole, which is considered as the family of new mercazole, okay? And the second is the PTU, propionthiouracil. In general, the methimazole and the carbamazole is having less side effects. So in general, it's actually preferred drug of choice, except in pregnancy, we use PTU, in particular in the first trimester, because it's less teratogenic, okay? And we monitor the TSH then and the free T4, but it will take time, especially the TSH, to be normalized. What are the side effects of both PTU and methimazole? Notice the agranulocytosis, okay, which is basically abnormality or inability to produce white blood cell. Huh? And the way we can actually advise people, first, we can actually regularly check the CBC, so check the white blood cell, but we also usually advise the patient to seek medical attention if they have any fever or sore throat. Because if you have low immunity, if you have no white blood cell, usually you are prone to have infection, in particular sore throat from a streptococcus, okay? Others, you may have actually cholestatic jaundice. They also both can cause hepatocellular toxicity and arthralgia, okay? So medical, beta blocker, in particular propranolol, we can give it for symptoms control, okay? So it would be only for a brief time till the symptoms settle down with the thyroid medication. Symptoms like tachycardia, atrial fibrillation, a tremor, all can be treated by beta blocker propranolol in particular. And then once the dust settles, once the disease has been controlled, you can actually withdraw the beta blocker. Other medication, they're actually very rare being used, cholestyramine as well as iodate sodium, very seldomly used in the clinical setting. Surgical therapy, well, you always can have the option to actually do a subtotal thyroidectomy, but be mindful that we always actually give them anti-thyroid drug till the thyroid become in an euthyroid level. We don't want to operate in people with hyperthyroidism. It's not a good timing to operate in someone already have an excess in their thyroid hormone. So we usually control it with the medication, and then we do the surgery. What are the complications? Of course, one of the biggest complications is actually to develop hypothyroidism, and this is almost expected by doing the surgery. Almost all people with a subtotal thyroidectomy will need a thyroid replacement, but also you may have hypoparathyroidism, because when you take the thyroid, you may take the parathyroid gland with it, and also recurrent laryngeal nerve injury. And if you guys remember from your anatomy, that the laryngeal nerve run very close to the thyroid gland. Third is the radioactive iodine therapy, which basically you give them a radioactive therapy to basically get rid of their thyroid glands altogether. It's very preferred treatment because it doesn't include surgery. It's one-day kind of intervention, and of course, you will end up having a hypothyroidism. Okay, and please don't forget that whenever you take this radioactive iodine therapy, females should avoid getting pregnant for at least 6 months after the radiation, because it's very, very teratogenic. Okay, how to manage ophthalmopathy in particular? Well, you need a coordination between the endocrinologist and the ophthalmology. We actually give them steroid to settle down their eye symptoms, especially if you're going to do the radiation, okay? So you give the radiation, you give the steroid, because giving the radiation without the steroid may worsen the eye symptoms. So it's something you don't want that to happen. So basically we give them together. So if anyone having eye symptoms, they should be evaluated by ophthalmology, and they should get a course of steroid along with their radiation treatment. During pregnancy, which is, as we mentioned, pregnancy can precipitate grave disease, and this is why we talked about it in detail. Can you mute yourself, please, kindly? Guys, can everyone mute? Can all mute yourself, please? Okay. So during pregnancy, well, the radiation therapy is contraindicated because it's so teratogenic. We talked about the PTU being preferred over the metamizole and the other group, and the reason is it's less teratogenic. So both they are teratogenic, but the PTU is less teratogenic. We always like to keep the free T4 at the upper limit of normal. This is mostly for the baby. PTU can be taken throughout the pregnancy, and if you're going to proceed with surgery, usually it's been done in the second trimester. PTU also is safe during lactating and breastfeeding. Okay, any question about Graves' disease, guys? Okay, so the others are less important, honestly. Like if you guys master the hypothyroidism, and particular Hashimoto and the Graves' disease, I think this is would be very nice. The others are really less common, so they are more rare and really need a specialist. So even family doctor, even general internist, they may end up referring the patient for endocrinology, but know at least how to diagnose them, how to differentiate between Graves' disease and the other types of hyperthyroidism. For example, toxic adenoma. Toxic adenoma, that's meaning one of part of the glands, of the thyroid gland, it's actually over producing a thyroid disease. So it's functioning thyroid adenoma, usually happen in elderly people, not in the middle age. Symptoms are basically matching the hyperthyroidism symptoms, even the biochemical lab. So you will see a suppressed TSH, high T3, slightly high T4, and focus in the examination. You're not going to have ophthalmopathy. Ophthalmopathy is really mostly for a Graves' disease. When you do a thyroid scan, remember, when you do a thyroid scan for Graves' disease, the whole gland in Graves' disease is going to actually shine. It's all going to be actually active. But in actually toxic adenoma, there's only going to be one or sometimes couple of hot nodules, okay? And the rest going to be actually suppressed. It's just one very active thyroid adenoma, okay? Treatment is exactly the same of Graves' disease. So you can start with medication, you may end up doing surgery. Toxic multinodular goiter, it's basically instead of having one nodules, the whole goiter is actually having over production of thyroid hormones. It can occur in elder people, especially with long-standing multinodular goiter. This phenomena of someone called Jod Basedow phenomena is basically having hyperthyroidism precipitated by iodine intake. So people don't take iodine and all of a sudden they take, it may actually precipitate toxic multinodular goiter. In the scan, the whole goiter going to be actually shining. Some medication may actually precipitate hyperthyroidism and toxic multinodular goiter, including amiodarone. Treatment, again, Graves, as of Graves' disease, but because this is actually multinodular, not only one, surgery can be actually preferred. Any question, guys? Okay, subacute thyroiditis. So this is actually all driven usually by a virus, okay? And we placed it at the end for a reason, and you're gonna know why shortly, okay? So usually those people will have a viral illness like an upper respiratory tract infection preceded their subacute thyroiditis, and sometimes they're not gonna have it. They're just gonna present with subacute thyroiditis. The key feature, of course, they're going to have fever, but they're also going to have a tenderness, a soreness in their neck, okay? When you talked about Hashimoto, when we talked about hyperthyroidism, we didn't talk about the thyroid glands being actually sore. It's like basically painful. This is actually classic for subacute thyroiditis. And from its name, there is actually an inflammation in the thyroid. In physical examination and in history, notice that they actually sometimes present with the symptoms of hyperthyroidism, but actually with time, they will flip. Some of them, they will flip to hypothyroidism. So sometimes they will present with feature of hyperthyroidism, and this is usually with a sore in their neck. But the late phase of subacute thyroiditis, it's actually having hypothyroidism, okay? So in physical examination, no eye involvement. The thyroid is exquisitely, like it's so tender in physical examination. They may present with tachycardia and tremor like any hyperthyroidism disease. Initially, the T3 and T4 are going to be elevated, and they're going to have a suppressed TSH. This is classic as hyperthyroidism. But when the disease progresses, the T3 and T4 will drop, and the TSH will rise. Basically, they will enter a phase of hypothyroidism. Even the uptake scan initially going to be low because the thyroid gland is actually hyperfunctioning. And then when it's recovered, it's going to be the other way around. ESR with an inflammation marker going to be all over like it's going to be all over the roof. It's going to be elevated. Thyroid antibodies usually are not detectable. How to manage it? It's basically managing the symptoms, okay? So you give Tylenol, you try with NSAID. Sometimes you end up giving them steroid if it is just too tender for them. It's basically as an anti-inflammatory medication. And when they flip to the hypothyroidism phase, you may end up actually give them levothyroxine to replace their thyroid hormones. Other very rare form of thyrotoxicosis. So thyrotoxicosis factitia, basically taking an excessive levothyroxine. And this is actually started to be common nowadays because people taking the levothyroxine as a weight loss and for weight loss. And it's actually even those weight loss sometimes herbal medication, and they give you like a mix of herbal medication, and sometimes it's actually containing levothyroxine from animal sources, okay? Because they take it from other animals and they mix it and they represent it as a weight loss medication, while in fact it's all thyroid hormones, okay? Stroma ovary, it's very rare teratoma of the ovary with the thyroid tissue on it. And of course, when you have a thyroid tissue, that makes you prone to have an excessive thyroid hormones. Hydrated for moly, it's basically getting pregnant with hydrated moly, and this gonadotropin, it's actually can stimulate the TSH. It have some TSH-like activity, so it will actually ask the thyroid hormone to release more thyroid hormone. So The fourth is basically TSH secreting pituitary adenoma. Basically, you have pituitary adenoma secreting TSH, going to the thyroid hormone, asking it to release more of thyroid hormone. But notice in this case, the TSH going to be normal or even elevated because it's basically TSH secreting adenoma. Okay, thyroid storm. So thyroid storm basically, usually when you have a state of hyperthyroid patient, so you have a hyperthyroid disease in a patient, and then this storm being precipitated by an event like infection, by surgery, or by cold turkey stopping the anti-thyroid medication. This is all may lead to a thyroid storm. What's thyroid storm? Is basically a clinical cluster of symptoms including fever, agitation, and sometimes even coma, anorexia, tachycardia, sometimes even heart failure, sometimes hypotension and shock and confusion. Okay, how do we treat? Well, we treat with a lot of fluid, electrolyte replacement. You may sometimes give them vasopressin to improve their hypotension. You try to cool them down with blanket and Tylenol, as well as you give them beta blocker propranolol to try to slow the conversion of T4 to T3, but be mindful for the heart failure. And then you give them, of course, anti-thyroid medication. PTU is the drug of choice, and you give them actually a very high doses, as well as you may give them actually even dexamethasone. Most importantly, actually, to identify and treat the precipitating factor. Okay, last but not least, non-toxic goiter. Basically, you have an enlarged gland from TSH stimulation, which is the result of inadequate thyroid hormone synthesis. So the TSH is just trying to push the goiter to release more of the thyroid hormone. This is most of the time, it's actually from iodine deficiencies, but also early stage of Hashimoto thyroiditis before you have a low T3, T4, you may have non-toxic goiter. How to treat? You basically treat the cause, and if it is autoimmune like Hashimoto, you just actually follow the course, and whenever they need hormonal replacement, you start them on that. Okay, you guys can see the goiter over here. Huge, huh? How to manage it? Well, we give them levothyroxine. It's not suppress, it's actually, this is to suppress the goiter, basically. Notice that the doses actually are less than the one for Hashimoto. So for, and the aim is basically to suppress the TSH to a normal level, basically. And if you have any obstructive symptoms, because this picture, you have to make sure that the goiter itself, it's not compromising the airway or the swallowing, because if that's the case, they will need an urgent surgical intervention. Last but not least, thyroid nodules. Basically, in physical examination, you may find basically just a thyroid nodules in physical examination. You do all the workup and it's turned to be benign. It can be teratoma, lipoma, hemangioma. If it is actually the thyroid nodules, it's more than, let's say, 1 centimeter, you definitely need to take an FNA biopsy, as well as some of the feature in ultrasound may suggest a malignancy. So you may end up actually having the nodules to be sampled. Okay, you guys see here, this is basically all the thyroid being very active. It can be with grave disease or multi-goiter nodules. I don't think we're going to talk about thyroid cancer. I think it's beyond the scope of this lecture. You guys have any questions so far? So for those interested, they may go over the thyroid cancer, but I really think it's beyond the scope of today's lecture. Any question, guys? You can open your mic and ask question, or you can actually type it in the chat. You guys want us to go over the thyroid cancer? Because we still have time, a lot of time actually. Okay, so thyroid cancer, it's actually one of the rare cancers can be managed actually by an endocrinologist. Sometimes doesn't need actually an oncologist to treat the thyroid cancer. The most common cause is actually papillary carcinoma. It's actually up to 75% of the thyroid cancer end up being papillary carcinoma. 75, it's a good percentage. Others, follicular and medullary are others. So what are the symptoms? Usually, it's actually basically just a nodules in the examination, okay? Cold meaning, solitary cold meaning when you do the reuptake, it doesn't take actually the radioactive scan. That's meaning this nodules, it's being actually autonomous. And the radioactive scan. There is some features in ultrasound may suggest of carcinoma based on size, the presence of calcium, especially micro calcification. They're all concerning feature in ultrasound. 10% of papillary carcinoma, which is the most common cause of thyroid cancer, may present with even enlarged cervical node, and as you can guys guess, having a positive cervical node that actually have a poor prognosis. Okay, late stage can be spread to the lung, so this is the usual metastasis sites. Okay, those tumors can be secreting some of the thyroid function like thyroglobulin, and this markers can be used for recurrence. So when we treat people for thyroid cancer, we can use the thyroglobulin as a marker of recurrence or metastasis in the future. Follicular carcinoma, which is another type of cancer, is basically capsular or vascular invasion. This is definitely more aggressive than the papillary carcinoma and can locally invade to a lymph node or blood vessels, which is not good because any spread is bad, but also can have a local extension to the distant blood stream, metastasis to bones, lung, as well as to viscera. Okay. Again, thyroglobulin secretion by follicular carcinoma can be used to follow up the course of the disease. How to manage the papillary and follicular carcinoma? Well, you have low risk and high risk. A low risk, which basically people young in age, this is the primary lesion. It is less than 1 centimeter. You have no evidence of a spread. You basically take the whole loop out. So it's basically surgical as a preferred option. For those people at high risk, you may end up actually doing a total thyroidectomy because you don't want a micro separate happen or a recurrent in the future, and you may end up doing a neck dissection to take the lymph nodes out in case of lymphatic spread. After the surgery, it can be followed actually by radioactive ablation therapy. And the reason, when you take or when you surgically take the whole thyroid out, there is still a chance that you left some leftover tissue. You don't see it in the OR, but it's actually present inside the body. So you'd like to wipe out all of the thyroid tissue. And of course, they're going to be in a state of hypothyroidism after, so you'll have to replace them after. Again, we follow the thyroglobulin level for in the future to see if there is any evidence of recurrence or metastasis somewhere else. And you can actually do even a thyroid ultrasound. Even if the thyroidectomy done, you still can do that, looking for a recurrence locally or in the lymph nodes, as well as the whole body. Because don't forget, sometimes there is going to be a micro metastasis. You don't see it in the naked eye, but it's present. So with time, it's going to grow in the lymph nodes or somewhere else in the body, especially in the bone and in the lung. Medullary carcinoma, which is another type of thyroid cancer, and the parafollicular cell. This is way more aggressive than the other two forms of papillary and follicular carcinoma. And this time, we talked about briefly or previously about the thyroglobulin. For the medullary carcinoma, another surrogate is the calcitonin, as well as the CEA as markers for diagnosis, as well as for follow-up. Medullary carcinoma are sporadic, but there is also familiar types. You guys probably heard about the MINS. So a lot of them, they actually containing a medullary carcinoma as part of the cluster of symptoms they are having. Of course, for diagnosis, we need biopsy. And the people with MINS, we usually actually screen them based on the type and how strong the family history is. Anaplastic carcinoma is the worst among them when it comes to the prognosis. A lot of time they will enlarge fast and they will cause some pressure symptoms, including dysphagia, vocal cord paralysis, death from a massive local extension usually occur in 6 to 36 months. So it's actually very significant, very bad prognosis, and they can be resistance to a lot of types of therapy. Okay, time for question, guys. Please, 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 question. Question, guys. No question. هذا معناته ما سوينا شيء بالمحاضرة.
لا دكتور، معناته شرحك كان واضح يا دكتور.
لا لا لا,
إن شاء الله.
ما في واضح. Believe me, if no question, that's meaning أنا مقصر أو أنتم ما صحصحتوا. Okay. Okay. الله يعطيكم العافية. We're gonna take a break, guys. Shall we regroup at 9:30 ولا تبون نبدأ على 10؟ 9:30 is better. في ناس 10 وفي ناس اوكي اعتقد الغالبية 9:30. اوكي so let's do it at 9:30.